it's a really pleasure for us to be here in this wonderful day in Chicago, our hometown, with a very nice weather that we usually don't have. So we had to take advantage of everything. So I'm Dr. Luis Gonzalez. I'm the Assistant Director of Infectious Diseases and Immunology at Core Diagnostics. It's a real pleasure for us to have the opportunity to interact to you and to talk to you guys about an important topic about our HIV epidemic. We want to address
I'm going to say, can you hear me okay? That's okay?
That's totally fine.
Yeah, so why we choose this topic? Because we have 40 years of the HIV epidemics going since in the 80s when we started doing the first diagnostic of the first cases in San Francisco, in California. And then later on, we find out there was a new virus that was really immunocompromised the patients. That the 80s also was the timing when the first HARTs came on board, when the first drugs, antiretroviral, came on board, but also an important timing when the first diagnostic device approved by FDA was done, especially by our company, by Abbott. So we're really proud of all the work that we've been doing and supporting the HIV epidemic. So, but at the beginning of the epidemic, when we start working with our first patient, all the cases started to showing up, diagnostic was done. We have a lot of expansion of the epidemic around the world, so we had to extend the diagnostics as close as possible to the people in the different regions, not only in the United States, of course, in Europe, but also in Africa, which is the heaviest continent hurt by this epidemic. And so the idea of the strategy on those times was try to create all those VCT center of diagnostic when we include diagnostic all over the place because the epidemic was into the exponential increase phase. But times are changing, right? Then we had to move treatment. We had to make sure the diagnostic was there for kids, for babies, for mothers to protect the transmission. But then today, when we start seeing WHO and CDC established the 1990 goals and 1995 goals and try to guide the countries in what as the north that we have to go in to eliminate this epidemic to the world. But there is a point that we are, facing a flat line in our incidence cases. When we analyze data from many other countries, we are seeing that we are reaching a point that there is no way that we can really put down the incidence, including the United States. If we analyze that in the last 4 or 5 years, we are going to see that we reach a plateau. And there is a missing part. It's something that is missing there to really put down the incidence of new cases and really eliminate and try to eliminate and have a generation free of HIV/AIDS in the world. And one of the reasons is because the dynamic of the virus, it makes an initial going up of the viral load, and we only do diagnostic a little bit later on. So that means that we have a bulk of people who are always going to be positive, and they are going to be transmitting the virus in a much higher level in that specific period of time that we call acute phase. So strategies have to change in order to be able to target where the source is of the virus and make sure that we can eliminate as much as we can. On the other hand, we also have now prophylaxis, PrEP, which is been an extremely useful tool to try to avoid negative patients to become positive because they are vulnerable populations. So PrEP are becoming a very important element of the control of the epidemic. So both things, diagnostic and monitoring care of the patients and try to prevent new patients coming on board are the two biggest strategies. For that reason, we are inviting Dr. Paul Drain. He is a medical doctor, especially infectiology. He is also a clinical research in everything that has to do with epidemiology or infectious diseases from University of Washington. And Paul is a key opinion leader around the HIV and other infectious diseases. But he also has the experience working in the University of Washington in Seattle in the very different environment like United States infectious disease portfolio, but also working in places like in Durban, South Africa, or Vietnam, or Bangladesh, in other infectious diseases, especially in Africa on HIV. So he had that balance of, a system in places like United States, but also a system in places like Africa, where we probably need to bring most of the attention in order to help them to really reduce the number of cases around the world. So I will introduce you now, Dr. Paul Drain. I will make sure that we are supporting this. We are supporting him to come here, but he's here as as a research, right? So the comment that he may have are not necessarily aligned with the policies or with the product that we have. So it's really important to understand that he is an independent researcher and he's going to be talking about his point. This is our disclaimer. So individual results might vary, and this presentation is not intended to represent or guarantee that any laboratory will achieve the same or similar results, right? So I think this is very clear. This is a scientific event, so thank you very much. Now I will give the stage to a much nicer guy, Dr. Paul Drain, to talk about his experience in that area.
All right. Thank you. Oh, thank you so much. Thank you, Luis, for the very nice introduction, and thanks to Abbott for the invitation to be here today. Can I just do a mic check? Valerie, you can hear me okay? Yeah, it's good? Okay, perfect, thanks. It's kind of a new setup, it's a little interesting. Well, great, I'm an infectious disease physician. I see HIV patients in our clinics and our hospitals. I'm based at the University of Washington in Seattle. I also run a clinical research group where we focus on diagnostics. We do a lot of HIV, tuberculosis. We did a lot through COVID. We're happy to really wind down our COVID diagnostic program. And today I'm going to talk to you about some diagnostic strategies in the modern HIV era. I'll speak for about 17, 18 minutes, and then we'll have some time for questions and answers if you have any. And I'm happy to stick around later if anybody wants to talk and dive a little bit deeper into some of these topics. Okay, just my speaker disclosure. So I'm going to go through some of the current HIV pandemic and goals that we have both globally and nationally. We'll talk about diagnostics for HIV prevention and acute infection. And we'll talk about two areas that I think are really important: the need for early diagnosis and treatment initiation, so how we can improve our diagnostics in that space. And then I want to talk about the value of drug concentration testing. This is an area that me and my research group have really been focused on in recent years. Okay, so let's just start and look at the global HIV estimates. This is from 2024. So our most recent numbers, we have almost 40 million people living worldwide with HIV. New HIV infections each year is around 1.3 million. We still have over 500, 600,000 deaths per year from HIV/AIDS. This is not going anywhere. And furthermore, we're not achieving our current global goals. So these are the goals that are set forth by the World Health Organization. You can see infection on the left-hand side and deaths on the right-hand side. We have a very nice trajectory. We're doing well. But I've really highlighted the dots down at the bottom, which are the actual targets for 2025. And you can see we're not really getting there. We need some new tools, or we need a new approach. So this is a strategy that the World Health Organization, UNAIDS, has set forward, a 95, 95, 95 target. We want to get 95% of people diagnosed, 95% of people started on therapy, and then 95% of people virally suppressed and on medications and doing well. We're having challenges at all three of these different pillars for treatment. Let's look at HIV in the United States. So currently we have around 1.2 million people living with HIV in the United States. We have about the same number of people that are considered to be high risk and receiving PrEP. So this is the either the once-a-day oral pill that people can take to help prevent from getting HIV. There's now 2 long-acting injectables that have been approved. We can talk about those a little bit more as well. But we're still seeing around 30,000 new HIV infections per year in the United States. These two graphs represent where we are with new HIV infections. So the graph on your left is showing our estimated or our projected level of new infections, which is the straight line at a very steady decrease that was projected by the CDC. And you can see the actual number of new HIV infections per year is the blue line. And now it's really kind of horizontal. We seem to be really stalled between 30 and 35,000 infections per year. This is how we're doing with the HIV care continuum in the United States. We're still having a problem getting people diagnosed, started on therapy, and then virally suppressed as well. Okay, so I want to talk a little bit about diagnostics for both PrEP and HIV infection, or ART. So for PrEP, for prevention, we have 4 different types of diagnostics that we can use. One is an antibody test, which is really just showing that you've been infected, you've developed antibodies, you've probably got infected at least 4 to 6 weeks before the antibodies show up. The tests that we prefer to use are antigen and antibody tests. This is the P24 antigen along with the antibody testing. This is really what's recommended by the CDC. Of course, we have HIV RNA, which is looking at the viral load, which can help us with acute infection. And I also want to talk about drug concentration. So I'm going to talk about the two that are highlighted here in red and why I think we can do a little bit better. So let's talk about ART. So this is just the diagnostic kinetic curve that you can see in the figure. So you can see that HIV RNA or the viral load testing can pick up HIV pretty early on in the acute infection, as early as 10 days. The antigen antibody is in the green. That's including the P24 antigen, so it improves on just antibody testing alone. I think we can still move that curve further to the left and try and pick up people earlier, because as those people are picked up, then hopefully we can decrease transmission onto other people. So again, I want to talk about those two areas in red. We have diagnostics for acute diagnosis. We have it for ART initiation, which I think we have a very good panel currently of diagnostic tests. And then I want to talk about ART monitoring as well, and this is where the drug concentration testing comes back in. I'll talk about this towards the end. Okay, so how about acute HIV infection? Why do we want to test for acute HIV infection? Well, I told you that the number of infections seem to be pretty consistent from year to year, so we have to get people diagnosed earlier, get them treated so they can be suppressed. Once they're suppressed, their risk of transmission is very low. So there's a real value for early diagnosis and treatment for acute HIV infection. On a personal level, it's also having immunological and virological benefits. So we reduce the amount of virus or the viral reservoir that would be in their body if we get them started on treatment faster. It's also better for their immune system. And the community benefit, as I mentioned, is it's really going to diagnose people faster and decrease ongoing HIV transmission. So both personal and community level benefits. Okay, so what do our current diagnostics for acute HIV infection look like? I talked about this a little bit already. So we have the antibody tests, which are really just going to pick up infection usually about 6 to 8 weeks after somebody's already been infected or exposed. So 23 to 90 days after exposure. What's really preferred now are the antigen antibody tests. These are a combination. These are lab-based tests, but they're also available as rapid diagnostic tests as well. So picking up infection a little bit earlier. And then there's also PCR or NAT-based tests, which I'm sure you're all aware of. And really getting people a little bit earlier. Obviously, there's an expense that's added to this. So the proposition of trying to do PCR-based testing on everybody at frequent intervals may not be cost-effective for the system. And you can see the FDA-approved tests that are listed over on the right-hand side. I've just bolded the antigen antibody test because there's multiple lab-based tests. There's only one rapid test that's currently approved by the FDA. So again, I think we can have more options and actually do better with what we currently have. Okay, so the CDC guidelines for monitoring PrEP, they were last written in 2021. I think they're due for an update, and there's discussion now about updating the PrEP guidelines, and I'll walk you through what I think might change. But first of all, we need to confirm somebody's HIV negative before we start them on PrEP. This can be done with the HIV antibody antigen test. It can either be plasma, which is preferred by the CDC, or an RDT. We're also supposed to test if there's an exposure within 4 weeks, or if somebody has signs or symptoms of acute HIV. Again, this should be done with an antigen antibody test, not just the antibody test alone. And somebody can also get a quantitative HIV RNA or a viral load PCR test. This is where it gets really tricky. We need to monitor people for possible HIV infection while receiving PrEP. The CDC recommends that we do both an antigen antibody test and also a quantitative PCR or RNA test. The IAS, which is the International AIDS Society, recommends only the antigen antibody test and does not recommend the HIV RNA test. And you may know that the oral HIV antibody test is not recommended for PrEP monitoring. So just recently, there was a study that came out of the CDC. We really looked at the utility of doing the HIV viral load PCR test they really found that it was not cost effective to try and do PCR testing every 3 months. And most of our providers in our clinics now are really just doing a lab-based antigen antibody test. There are some clinicians that are doing HIV RNA. They want to be a little bit cautious. They are following guidelines. But I think as the CDC reevaluates the data that we currently have and works on new guidelines, my guess is that they might drop the requirement for every 3 months having a quantitative HIV PCR assay and just move to every 3 months of antigen antibody testing. We'll have to wait and see what the CDC decides once they review the data. Okay, and there's also some real-world data for acute HIV testing. Early diagnosis can reduce transmission by up to 89%. So this really kind of gets to the need of why do we need to find acute HIV infection. There's a couple of trials that were done with CAB-LA for PrEP. This is the cabotegravir long-acting injectable. They found that the long-acting has an early viral inhibition called LEVI. So there's a particular syndrome that this causes. In these cohorts, the HIV RNA testing was commonly a false positive, and oftentimes these people required retesting using an antigen antibody test to really determine if they were indeed HIV positive or infected. Okay, so just a brief summary on diagnosis for acute HIV infection. As I've said a few times, the antigen antibody combination test is really preferred at this point. It's better than antibody alone because it's getting people earlier in that acute phase window. It allows for early and accurate diagnosis for treatment, and it appears to be the most cost-effective for PrEP monitoring and widespread screening. I'm anticipating that the CDC is probably going to at least decrease their emphasis on HIV RNA testing or viral load. It remains costly. It doesn't seem to be cost-effective for PrEP monitoring and screening. And again, there's many false negative results that we've seen through the CAB-LA studies, and we'll have to see about some of the other PrEP studies as well. Okay, so I want to talk briefly about the value of drug concentration testing. This can apply both for PrEP and for ART. Just to say that, adherence for both of these is really critical. So it should be pretty apparent that if somebody's not taking their PrEP or hasn't received their injection, the PrEP is really not going to be effective for them for preventing HIV. The same is true with ART. We need our patients to take at least 5 or 6 days of ART per week to keep them virally suppressed. And this is research that's been going on for the last 20 plus years. We know that adherence is critical. The tools that we currently have for adherence is either self-reporting, which would be something like pill counting or filling out a questionnaire. We know with multiple studies, and I do a lot of studies in sub-Saharan Africa, this is really just not accurate. It really depends on that relationship between the patient and the provider, if there's trust that's built up and if they want to be forthright. The other options that we have is mass spec testing. You can see that's pictured here in the bottom right. And this is just simply too costly to do at a programmatic level. So we do a lot of clinical studies. We usually pay around $200 to $300 for one clinical mass spec sample for our research programs, and it's just untenable to think about doing for a public health program. Okay, we've done a lot of work in the last several years on a rapid diagnostic test that would test for urine tenofovir. So tenofovir is in both oral PrEP and it's in the first-line recommended therapy for ART. So it's in the global fixed-dose combination pill, and we use it very commonly in the United States as part of the NRTI backbone. So it's very common, and it's detectable in urine. The problem with the tenofovir in urine is it has a very short half-life, so typically just about 20 hours, and it really just measures recent pill ingestion. So if somebody has taken a pill within the last 24 or 48 hours, we can detect the tenofovir in urine. The problem is it's subject to the white coat adherence, so if somebody's going to go to see their provider and they're going to take some pills beforehand. I mean, I know I went to the dentist a couple weeks ago and certainly did a really good job brushing my teeth and flossing, make sure everything looks as good as I can do. So it is subject to white coat adherence. And so what we really need is a good long-term drug concentration that we can measure. This graph is just showing one of our studies showing that the urine tenofovir really correlates with when somebody last took their dose of tenofovir. So we've been working on a study of looking at how well this tenofovir works, and we get some really mixed results. This is a very complicated graph, and I'm not going to walk you through all of it. It's really just to say we did a randomized trial in sub-Saharan Africa. This was in South Africa. We took 2 arms. We did monthly point-of-care urine tenofovir testing versus just the standard of care. So that's simply asking, have you been taking your pills? Are you doing okay? Do you need any help with that? The control arm is shown at the top, and what you see is that tall bar all the way at the left of the control arm. Those are people that have no detectable drug in their system. So these are people that were not taking any medications when we measured them by mass spec testing at about 6 months after starting therapy. And what you see on the right side is that we got more people taking drugs. So that really tall bar at the left has now decreased. So now with some adherence counseling, we're actually getting more people taking drugs. And we've been trying to shift that curve more to the right, which we were able to do in this study. But again, you can see these graphs are actually pretty similar. And we didn't see any real difference in HIV viral suppression in this cohort. So again, it's kind of grounding me to say the objective counseling that we can do with a urine tenofovir is helpful, but we still need better biomarkers and better measurements to help people suppress their viral load. Okay, so as part of these studies, we've also been looking at drug concentrations that are associated with efficacy. So this can be viral suppression. And this is just showing you as we look at different levels of tenofovir diphosphate, which is a long-term measure of tenofovir, we can identify a more accurate level, and we can also correlate that with viral suppression. So now we have a good biomarker. It's an intracellular tenofovir diphosphate, has a very long half-life of about a month. So now we're looking at the urine tenofovir being a very short-term blood glucose test, if we want to use the diabetes analogy, versus a hemoglobin A1C test, which is going to give us a very good long-term measure of how people are doing taking their medication, so we know where to improve that adherence counseling. The challenge is there's many reasons for drug variation among these patients. So we really need to kind of dial this in a little bit, and this is some of the work that's ongoing. So now we're working on a blood-based drug concentration assay. You can see there's differences between the tenofovir molecule and the tenofovir diphosphate in terms of half-life. And I think the graph at the right is hopefully showing you the variation in drug concentration. You can see with the urine concentration at the top with the short half-life, we get these big peaks and troughs in drug concentration. If we can use a long-term metabolite, you can see it's really kind of steady state, and we get a better picture of somebody's adherence over time. So now we're working to repurpose our tenofovir antibodies that we've used for ELISA and putting them on a blood-based assay and platform. We've also thought about combining the long-term tenofovir diphosphate testing with other lab testing. So now if we can combine the adherence with viral load, we'll have more information, and that would inform who needs to then go on for HIV resistance testing or additional counseling for those people that are on PrEP. So we're just completing this study in Seattle. It's called the RESTRICT study. It's funded through the NIH. We've been measuring drug concentrations in hundreds of people taking ART and PrEP. We've been collecting all types of biological samples, including plasma, whole blood, DBS, urine, oral swabs. We're really now comparing the tenofovir diphosphate in DBS, and we're measuring it by mass spec at this point because we want to transfer it onto something that's much easier and simpler to do. We're also doing something called a discrete choice experiment. We really want to understand from our patients what kind of testing they prefer, where do they want to do their testing. We're finding some people want to test themselves at home. They want a home-based test because they say, look, I just want the privacy. I'm happy to share the results. I just want to know and have that privacy. We're working to understand the combination value with our hepatitis B, because tenofovir is also in hepatitis B treatment. And then we're developing tools that we can evaluate in future clinical studies. And we just completed our enrollment, so we're working through the data And hopefully we'll be able to present this at one of the big HIV conferences coming up. Okay, so this is my final summary on drug concentration testing. There's uses for oral PrEP monitoring, along with HIV antigen antibody testing. We can monitor people for adherence to really optimize their counseling and support, hopefully prevent some people from acquiring HIV. We can ensure that they're having adequate levels of drug in their system to protect them from oral ART. So we're not quite there yet, but if we can monitor their drug concentrations, we might be able to change their dosage. And it's also useful for ART treatment monitoring. We can optimize their adherence, make sure they're having adequate dosing, preventing any unnecessary viral HIV resistance testing, which is expensive. And we're going to measure drug concentrations also in some tissues and lymph nodes as well. And we're going to consider the added value of drug concentration testing in well-designed clinical implementation trials. So anyway, I just wanted to thank you very much for your time. I think we're happy to take questions for a few minutes, and I'm happy to stick around afterwards if anybody has other questions. Thank you again.
Yeah, thank you very much. Before we move, we have a few minutes before I start pulling my ear because the time
Let me take this off.
So I want to make a couple of comments here. Number one, when we work trying to reach people in the acute phase, the incremental of the frequency of testing in vulnerable population is a key element. The second key element is the sensitivity of your test. You have to have a test to have a high level sensitivity of the antigen component, and also that the antibody can really pick up patients in that early phase. And that's even more important in PrEP. Because if you have a breakthrough, if you join someone into PrEP, which is in the acute phase, and you miss it, the moment that he takes the PrEP, he's going to be undetectable and invisible. But he's taking a not complete heart treatment. At some point, it's going to be a breakthrough in that patient, and that patient will come, that virus will come up in the genomic with some, secondary mutation. I mean, there is a controversy about primary, but secondary mutation for sure, that will make more easy for them to fail when they put in real treatment. So that's one important aspect. The other comment is about adherence. We always struggle in our program. In my previous life, I was in the public sector, of course, for many years. So on the adherence, we always want to be sure that people are taking the pill. Because when you order a viral load to a patient and he comes to you with a high level of viral load, your question is he taking the pill or he have a drug-resistant mutation? Moving to a genotyping is very expensive. And you have to be very sure, especially in low incomes, or on any places, even also work in Brazil. So even with the big network there, was always a challenge. So you have to be sure. What we do, we usually review the adherence with him and tell him come back in 3 months. So your patient has to come back 3 months later with another viral load. If we have at the same time an indicator, an official indicator that is telling us that the people is taking the pill, and then you answer the two things in the one visit only. So that's a great advantage. So those are the two comments that I want to make about the importance of adherence diagnostic in the acute phase. So, okay, thank you very much for your time in here. Thank you, Paul.
Yeah,
really
thank you,
appreciate having you here.
This is great.
Thank you very much.
Thank you.